Hello, everyone. Welcome to a webinar today on how to manage fatigue and improve your quality of life when you're living with serious illness. My name is Andy Esch. I am a palliative care physician and a consultant to the Center to Advance Palliative Care. I've been working in the field about 20 years, and fatigue is something that is super important to me because I would say that almost universally, my patients, no matter what their underlying diagnosis is, at some point in the experience of their illness, struggle with fatigue. And so I would imagine that those of you listening today have a similar story. So we'll work through some of the common ways people experience fatigue and some of the things that we can do about it to help you improve your quality of life. So we're going to look at what fatigue is. We're going to look at its many causes, ways it can be managed, and how palliative care can help. And then we'll go through some commonly asked questions at the end that I'll give answers to that should be helpful to you if you're seeking more information or have something that wasn't covered in the slides. So let's start with what fatigue is. It's extreme, persistent, and distressing tiredness. When I say fatigue, most people know what the experience is, even if they can't put it into words, because it's common. We see it all the time in my field in palliative care. The statistics tell us that it occurs in half to 3/4 of the patients with serious illness, but I would argue that that's probably closer to 100% at least at some point in time during the experience of an illness. And the other thing that happens is a lot of times patients don't recognize it in themselves. They may say they feel sick or they just don't feel good. They don't recognize that what they're feeling is fatigue. And it's important to talk about this and to address it because it's really debilitating on people's ability to function and enjoy their life while they're living with a serious illness. So the terms that people use to describe fatigue are tired, exhausted, having no energy, I'm weak, I'm sleepy. These are the things we commonly hear. They're kind of vague descriptors. No one comes in and says, I'm really fatigued. They'll use other words to describe it. So clinicians like myself will generally, probe a little bit more as to what exhausted means or what no energy means. And the important part of this probing, for me as a clinician, is to really get down to what's causing the fatigue, because there's so many causes. Low blood counts, also called anemia for medical providers, is a common cause, pretty pervasive through serious illness. Medication side effects, drugs that are interacting with each other can contribute to fatigue. People in pain. I will tell you, this is probably, it should have been a #1 on the list, because untreated pain or undertreated pain is a profound cause of people feeling fatigue. You just can't be in pain all day and not have it take its toll on you in the form of fatigue. Same with shortness of breath. Just struggling to breathe can be exhausting and make people feel fatigued. Loss of appetite, not having enough caloric intake to have energy can cause fatigue. Depression and anxiety have a complicated relationship with fatigue because fatigue can be a symptom of depression and anxiety. And fatigue can also contribute to someone being depressed or anxious. Why do I feel so bad? I should be feeling better. So there's kind of this cyclical relationship, which makes it, important for clinicians like myself to ask probing questions and find out, is this fatigue leading to depressed mood, or is this a clinical depression that is causing fatigue? And ultimately treating it is what we need to do, but knowing what that treatment is based on that relationship is important. And you may not think of it, but also, the stomach symptoms, gastrointestinal symptoms, feeling bloated, being distended, being constipated, really exhausting, and play into people's experience of their fatigue. So my approach to fatigue, and I think most people in my field, is to first identify what's going on. So we always hope that patients come in and tell us if they feel tired, sleepy, or weak, use one of those descriptive terms that we had on the previous slide. But it's also our responsibility as providers to probe a little deeper and to ask what's really going on in the home. So this identification of why are you feeling the way you're feeling is the first step. The second step is to evaluate. Understand that there's key areas affected or caused by fatigue. We'll get into these in the subsequent slides, but really looking at, okay, is it one of these 7 things? Like, what bucket do you fall into to explain why you're feeling the way you feel? And then the third step to managing fatigue is, after you've identified it, after you evaluated it, is figuring out how to treat it. And I don't want to discourage anybody, but there's no magic bullet for this. We don't have the magic fatigue drug that's going to solve it all. It's usually an approach that takes several different types of treatment into account to make you feel as good as you can. And combinations are not only maybe necessary, I would say the majority of the time are necessary to treat fatigue, but it is treatable. So I don't want to leave anybody discouraged here. We do really well treating fatigue, but there's no magic pill that's going to fix it all. So getting to the, evaluation, the 7 key areas include sleep disturbances. You're just not sleeping well. Maybe you're mixing your days and nights up. Maybe you're just not getting to sleep. Maybe pain's waking you up and you're not sleeping. Either way, whatever the cause, anything that's disturbing your sleep is a direct contributor to fatigue. Emotional distress, carrying the weight of living with a serious illness, its impact on you, your caregivers, the people that love you. All of this is exhausting and weighs on you from the minute you wake up to the minute you go to bed, and that can be really fatiguing. Activity level, what people do during the day directly affects how fatigued they are. So, one of the approaches we take when we talk to people about fatigue is sort of rationing their energy to do certain things that are important to them from a quality of life standpoint during the day, and then maybe resting at other times. So this activity level plays into it. Anemia or low blood counts, we talked about that earlier. If you have low blood counts, you're going to be more fatigued than somebody who has blood counts that are in a normal range. And we'll talk a little bit more about those. Pain is a huge contributor to fatigue. Unmanaged pain is exhausting, and there's no getting around that. So that's one of the things we're always on high alert for when we run into patients with fatigue. Good nutrition plays a component too. When you don't feel good, you don't always feel like eating. But when you do eat, what you put into your body can have a profound impact on how you feel and your experience of your illness. So, good nutritional habits. And again, we expand on all of these in the next few slides, but good nutrition is an important component. And then there's other issues that contribute to medical issues like, does somebody have thyroid that's not functioning well? Are they on medications that could be causing them to be sleepy? Some of the pain medications do this, and other meds as well. So these are the areas we're looking at: sleep, emotion, activity, blood counts, pain, nutrition, and then underlying medical issues. So sleep disturbances, having trouble falling asleep or staying asleep can contribute to this. Less restful sleep, snoring, limb movements, feeling sleepy or struggling to staying awake during the day. These are all questions that, as a clinician, I'm going to be asking my patients when they come in. What is the pattern? Is it, there's a big difference between, am I having trouble falling asleep because my mind's racing about my diagnosis and my treatment, versus I'm waking up from pain in the middle of the night. The approach I would take with those two is very different. So these probing questions are super important to go through with patients who have sleep disturbance. And then managing these, you try to follow a regular sleep schedule. You choose relaxing activities before bed. Try not to get yourself worked up before bed. You can drink warm milk. You can avoid caffeine, avoid too much fluid at the end of the night. This one I'm always a little bit hesitant about, because generally staying hydrated is a good thing, but overhydration at night can cause a lot of issues with having to get up and go to the bathroom at night. And then asking caregivers or sleep partners about snoring and or movements in the middle of the night, and then talking to your doctor about treatments for things like obstructive sleep apnea, which may be the cause of snoring at night and things like that, or medications for periodic limb movement during sleep. So there are some medications that can help with this, or interventions that can help with this. But the main key is figuring out what the underlying cause of the sleep disturbance is. So sleep studies is something that may come up. This is where you get monitored sleeping in a lab. It measures your brain waves. It tells how deep you're sleeping and for how long. It'll measure your oxygenation levels and analyzes body movements. This is typically ordered when, sleep apnea is highly suspected. And sleep apnea is just someone who has, at night when they're laying in their bed, they have periods where they have pauses in their breathing, and or a lot of deep snoring where there's sort of obstruction to the air getting into the lungs. And so when the clinician, when it's high in my list of what might be causing this patient to be awake, this is where we typically order a sleep study. Emotional distress is another trigger of fatigue. So, fatigue is physical, it's not psychological. But as I talked about in the earlier slide, depression and anxiety can make it worse. And there's this complicated relationship where these are so intertwined. It's almost impossible to be fatigued without feeling a little down about it. It's also pretty hard to have clinical depression and not have fatigue be one of those symptoms. So, I always say to my patients, even the ones that say I'm fine, I'm not depressed, I'm not anxious, I'm doing great, I just don't have any energy. I try to ask them to be open to them being contributors to fatigue. This might be depression. Do you mind if I ask you a few questions? And that's what I mean by clinician may screen for this. Asking somebody 2, in some cases 4 or even 9 questions, there's certain screening tools that clinicians use, and they may ask you about depression and anxiety in these tools, in these screening tools, just to make sure that we're not missing anything. Because it is important to distinguish between depression and fatigue, because the treatments are different, right? So fatigue, making you feel down, if you treat the fatigue, your mood might improve. If you're clinically depressed and you're tired because of that, treating fatigue is not what you need to do. You need to treat the underlying cause. So clinicians will ask a lot of questions to try to differentiate between depression causing fatigue or fatigue contributing to a depressed mood. And there's certain things we look to. Difficulty with concentration is more likely to be associated with the depression. Lack of being able to get up and go, feeling more fatigued in the morning, feeling hopelessness for what might happen months down the road. These are some of the things that we help to use to sort of pick out, is this depression or fatigue as the major contributor? But this is not something that the patient needs to know. This would be something that the clinician will work through with you to get to the bottom of. Activity level. So for me, this is where I spend a lot of time with my patients. Most patients with serious illness, they have fatigue, they have pain, they're short of breath, they might have nausea or constipation. And all of this contributes to reduced physical activity, and in some cases, even inactivity. And when you become less active, being less active leads to more inactivity, and it sort of becomes a snowball where it just takes on this life of its own, where it just becomes really, really hard to break that cycle and do something about your activity level. And that affects your ability to function and enjoy life. So what I always do with my patients is I focus on, let's do something today. You haven't left your house in a while. Let's get you to walk out to your front porch. And then maybe a week from now, let's see if we can get you to walk to the end of your driveway, to your street, and then back, or to your mailbox, or whatever it may be. And I really start slow with patients, because any little bit of activity is helpful. And if you start slow and you slowly build on that activity, you can really show progress. And patients won't notice this. They won't think much of, oh, yesterday I only walked to my front porch, but today I walked to the mailbox. So I always ask them to journal. I'm asking you to do a little more every day. Just keep a journal of what you did activity-wise. And you can see when people see they're making progress, that also has a snowball effect, and it builds on itself. So I really like physical activity as a treatment strategy, as well as a something that needs to be evaluated as a cause of fatigue. And journaling and starting slow and slowly building on physical activity is super important. So low blood counts or anemia. Anemia is not normal, so you always need to look for a cause. Causes can be many, and I won't go down this, this rabbit hole that I can as a physician of what all the causes of anemia are, but serious illness is associated with low blood counts in many cases. I would say the majority of cases. So, your clinicians should be doing a history, a physical exam, and some lab tests to diagnose anemia. It's not something that you can diagnose without a lab test and taking a good, thorough physical. Pain also, huge contributor, as I said, maybe the number one contributor. Pain needs to be assessed. It needs to be a good exam performed by your medical professional who's going to ask you questions about, when did your pain start? What have you tried that helped? What then, you're gonna go through a whole thing of when it started, how it's impacting your life. What do you do that helps? What do you do that makes it worse? And I always ask my patients, you don't need to come into the office to try to impress me. Like, if you're in pain, I want to know. Like, there's nothing heroic about under reporting how you're feeling. So if you don't tell me as your clinician or someone like me, then we don't know. So, don't be afraid to say, I'm having pain. My pain's not managed. Even if I've been the one trying to manage your pain for a year, don't be afraid of, disappointing me or making me feel like I'm not doing a good job. Like, I need to know that, because pain, fatigue, all these things are interrelated. And one of the things I think is so important for me and my work with patients' experience of fatigue with serious illness is to set achievable pain goals and using different approaches for it. So again, this whole idea, there's no magic bullet for it. We use things like cognitive behavioral therapy, helping you process how you're experiencing the pain in a more positive way. We'll use medications, over the counter, some prescription, that'll be part of it. Relaxation techniques, things like that are also super helpful as well. So setting achievable pain goals, meaning I might not be able to get you pain-free and still have you be awake enough to enjoy your life, but I can get you pain controlled enough that you can live every day and enjoy your life. But it may mean I use multiple approaches like therapies, medications, and relaxation techniques. Nutrition, again, loss of appetite and weight loss often contributed to fatigue and serious illness, seriously ill patients, and patients that have like a diagnosis, heart failure, cancer diagnosis, things like that. They will experience both fatigue and appetite and weight loss in many cases. So it's when that weight loss is 5% or more of normal body weight that we start seeing these physical and psychological distressors come through. So hopefully you're being weighed at every visit. This is being tracked closely, and as much as possible, I involve the dietitians or the nutrition specialists early, because again, in someone who's has appetite or nausea issues that is experiencing serious illness and treatment of that illness, making sure the calories that we get into the body are the best for you is really important. So again, if you feel like your appetite is decreased or you've lost some weight, this is something you bring to your clinician's attention as well. Other factors linked to fatigue, we talked about medications a bunch. Providers will go through your medication list, look at those for sedating medications, those medications that make you tired, or medications that might be interacting with each other. And tweaks might be made to your medication list because of this to see if it helps improve your fatigue. You may also be tested for other illnesses. Thyroid problems are kind of the classic one in medicine, that we test your thyroid function. That could be low thyroid, could be causing fatigue, or there may be other illnesses that are in the background that may be doing it too. So, underlying illnesses other than the one that we may be dealing with at your appointment may be contributing as well. So when I think about treatment of fatigue, it's a stepwise approach. I always I would say the majority of the time I talk to my patients with fatigue, and we get to this point in the visit where we start talking about what are we going to do about it? Because that's really what ultimately people want. It's like, that's great, doc. You did a really good exam on me, but what are we going to do about this? Well, because there's no magic pill that fixes this, we use a multi-pronged approach, and educating the patient, talking to them about goal setting, the expectation that 100% pain-free is not realistic for the majority of patients, but controlling pain to the point where we can improve quality of life is an expectation of mine, and I think should be of patients. So, reframing the fatigue within the context of what's realistic and what we can really do to improve quality of life is part of educating the patient on what to expect. So they're much more willing to go with the plan because you've talked to them about the plan and what to expect. Behavioral management, reframing things in the context of positivity, not in a way that's disingenuous, like not where I'm just telling people what they want to hear, but saying, your fatigue is expected. Your fatigue is, manageable. These are the things we're going to do, and helping people to create behavioral attitudes that are positive in the treatment of their fatigue and their illness versus something that's detrimental and more fatiguing. Exercise and medication also contribute. Exercise is probably the number one modality I use because everybody can do it, even those that aren't able to walk. There's the exercises that can be done in a chair, in a bed, and the impact is profound. And medications do exist that can help with fatigue. There's limitations to them, but we'll go through a few of those in the next few slides. So, patient education. Your medical professional should be validating your experience. This is normal. This is common. Give you a plan to manage the fatigue. May not be the plan you imagined when you walked into that office that day, but it should be one that you understand and you have a clear sense of how to execute it when you're outside the office. And then discussing and setting realistic goals. If I give you unrealistic goals and they're unrealistic, you're going to leave my office and not do anything. So go slow, build slow, set realistic goals. And patients really, when they understand this, they do really well with fatigue treatment. Changing and managing behaviors. So conserving energy, focus on ways to save energy, ask family and friends to do things you normally would handle yourself. Hardest thing for patients to do, especially early on in serious illness, is to start asking for help. They don't want to be a burden on their family or friends. But I will tell you, asking people to do concrete things that help you save energy and allow them to be involved in your care in a way they know is useful to you is a win for everybody. So, conserve your energy. Again, managing your behavior. Don't feel like, well, I used to be able to do all this, so now I'm going to be down on myself because I can't. I would say, flip that on its head. Say, this is what's most important to me, so I'm going to use my energy and do that. And all these people in my world that have said they want to help me, I'm going to find ways for them to take some of this stuff off my plate and help me. And it really is feel good for everybody in that way. So when you are managing your energy, work with how you feel. If you have more energy in the morning, schedule activities that are important to you in the morning. Work with the rhythm that you're used to with your body. Chart your energy levels over the course of the day. Figure out when you have the most energy and when you have the least. Journaling, again, super helpful for this. I have almost all my patients journal. Not a lot, even just a few lines every day. 3 p.m. felt good, 5 p.m. exhausted, didn't feel like eating, 9 p.m. went to bed. That may not seem like a lot. It's not a big burden to ask somebody to do, but if I get a couple weeks of information like that, you can see patterns start to develop, and then you can really get an insight of what it's like for this patient living with, what it's like for you living with this illness as my patient. And then reducing stress through mindfulness and other strategies. So these may be things your clinician talks to you about or even counsels you on, or might refer you to somebody else that can help you learn how to do some of this. But it really is about being conscious of your pain and using helpful strategies to emotionally and intellectually sort of process it and work with your plan that you set up for fatigue to find resolutions to it. And then make adjustments for low and high energy times. Again, just don't try to, if you know you're always tired at dinner time, don't schedule hard things for them, and don't feel guilty about it. And in your high energy times, this is when you do your graded exercise, the little bit more every day, or the little bit more every week if you can't, escalate every day. Make a list of things you want to do, try to get to those things during high energy times. And then again, I tell people to journal, because they'll see that in their high energy times, when they first start out, they may not be doing a ton, but then this eventually grows as they start building up some more stamina and reserve to the fatigue. Exercise, I think, is the mainstay of maintaining a sense of well-being and enhancing quality of life. Then exercise means different things to different people. For me, it's physical activity. It's getting up, walking around the room, maybe doing hand exercises. Whatever it is within how you're feeling and where you're at in your illness, there's always some physical activity that can be done. And it's important to do it, because even though most of us dread working out, once we do, we feel better after. And the same principles hold true for when we're ill. So physical activity is really important. Like formalized exercise rehabilitation can be effective means to restore your physical and psychological function. Not everybody's at that point where they can do that, but those that are, we use therapy for that. This middle bullet or arrow, super important. Start small. Everything counts. Everything counts. The things I have my really fatigued patients do at the start may not seem like anything. Go from lying in bed to sitting in bed. Throw your legs over the side of the bed the next day. The next day, maybe stand up at the side of the bed and then sit back down. And you just build on that. And eventually, if you start adding one more thing, you eventually get somewhere. Again, consider physical therapy where it's indicated and where the patient can tolerate it. And then, make it fun. And I think even more importantly than making it fun is, like, don't make it burdensome. If I ask my patient to sit up and swing their legs over the side of the bed and they haven't done that in a week or two, that maybe isn't fun, but it's achievable. And when they do it, there'll be a sense of, oh, I'm making progress, rather than, he asked me to get up, get out of bed, walk down to the mailbox 5 times today. There's no way I could have done that. So as part of making it fun is making it achievable. So medications to address fatigue. Inevitably, this is what people come to me looking for. And there are some things that help. Steroids can help. Megace, or megestrol acetate, is a medication that helps with appetite and a little bit with fatigue, is available by prescription. There are stimulants. These are drugs that get used commonly for people with attention deficit and hyperactivity disorders. They can be helpful in fatigue. And then there's complementary and alternative treatments too that, we know as clinicians, our patients generally, over 2/3 of them are on complementary and alternative medicine. So we need to be aware of these, and you need to make your clinician aware if you're taking something that is from the health food store or from the pharmacy, but not a prescription. And, so you can discuss the pros and cons, drug interactions, and things like that with your clinicians. So let's talk about each of them individually just a little bit. Steroids can reduce symptoms and improve quality of life in patients with advanced cancers. We know this from studies. It may be helpful in other illnesses. Generally, my feeling with steroids is this: I can give everybody a pretty good boost giving them steroids when they're feeling fatigue. There are some long-term side effects that are troubling, though. More susceptible to infection. You start depositing fat in certain places. You start getting weakening of bones. There's things that can happen when you're on steroids a long time. But if somebody's really down, really fatigued, and you want to get a boost out of somebody, these are an effective short-term therapy. Megace, or megestrol. Again, I talked a little bit about how it improves appetite. It's not the magic bullet for appetite either, but there are some studies that support that people do gain weight and muscle mass on Megace. It can help with fatigue and overall well-being. It has many side effects. Some of these are serious. The most serious of these is it increased your risks of blood clots. And the reason I call that out in particular is that inactivity in and of itself is a risk for blood clots. Cancer is a risk for blood clots. Some other illnesses increase your risk for blood clots. So if you start adding in a medication that it also increases the risk for blood clots, you got all these reasons you might get a blood clot, and it increases the likelihood you're going to get one. So we try to be pretty thoughtful about people we put on Megace. So stimulants, you know, I've used them in my career. These are things like, some of the name brands are Ritalin, Provigil, things like that. These are, again, medications that get used for ADHD or attention deficit hyperactivity disorder. They can give people an energy boost. They can also cause insomnia, which is trouble sleeping, which is a contributor to fatigue. So you have to be careful. When I use these medications, I start low. I use them in the morning, so hopefully that their activity lasts through the day but starts wearing out at night so people can sleep. But there's side effects: constipation, weight loss, because people are on stimulants. These function kind of like uppers, and so your appetite will be less, and weight loss is not desired for most serious illnesses. It can cause headaches, elevation in heart rate, and elevation in blood pressure. So again, there is a time and a place for these that can help, but this is something you just need to talk to your clinician about. So try them when you're persistently impaired and you're just having trouble getting up and going, and you've addressed other factors and nothing's really working. Give stimulants a try. Severe fatigue that prevents participation in exercise or behavioral management. Again, this is, you're so fatigued you can't even swing your legs over the bed. You might want to try a stimulant. Or one of the other reasons I use them is, what about the patient that's just too tired to even get out and go to their appointment? If they're not getting their disease-targeted treatment, if they're not getting the treatment that's going to help cure, slow, or sustain their illness and where it's at because of fatigue, this is a time where you start thinking about medications like this. And again, it's only for certain patients that don't have certain medical or psychiatric risk factors. So complementary medications, there's a bunch. The data on these is never as robust as the drugs that we prescribe for, but there is data that exists for a lot of these. And so what I try to do as a clinician is I just ask patients like you, patients feeling fatigued, living with a serious illness, just tell me what you're taking. Because what I do is I cross-reference that with the studies to know, do these things work for what you're taking them for? And are they interacting or hurting in any way with the medications your oncologist or heart doctor or lung doctor may be using? So, even things like ginseng or fish oil or melatonin, there may be potential drug interactions or things that may interfere with your ability to have your disease-targeted treatment. So I just want to be sure what you're on, that it has the potential to help, and that it's definitely not causing any problems. So ginseng is one people commonly use. A lot of drug interactions with ginseng, but there are some studies that suggest that it's helpful for fatigue. Fish oil or melatonin, there's no studies that confirm any benefit in fatigue. Melatonin does have some data on sleep and its use in delirium, which is like a reversible confusion that some people get. But there's not a ton of these studies, and they're not with a lot of people. So, this might be something, if my patient's on it, if they feel strongly that it's helping them and I know it's not hurting them, I may keep them on. So that's really what this is. It's a important discussion to have between the clinician and patients like you about, what are you on? Do you think it's helping? Do you feel better on it than you felt off of it? Because yeah, it may be doing that, but it could be doing all these other things too. So it's just a give and take. So what's palliative care's role in all this, and how can we help? So first, why don't we just talk about what palliative care is? Specialized medical care for people with serious illness, focuses on providing reliefs of symptoms and stress. And the whole goal of this is we want your quality of life to be as good as possible for you, for your family, for your caregivers, whoever's involved in your sphere. Palliative care is provided by a specialty trained team of people. This includes doctors, nurses, and other specialists, social work, chaplains. Some places have pharmacists or nurse navigators. It is some combination of people that work together with all the other people involved in your care to provide an extra layer of support and focus on things like fatigue that are impacting your experience of living with the illness. And one of the things I really try to say to my patients is when they come to see me, they're like, I don't know why I got referred to palliative care. I say, well, I can help. It doesn't matter, like, if you found out about your diagnosis yesterday, or if you've been living with this for years. Like, fatigue is fatigue, and I can help you, and I can make sure that we do it in the safest and most effective way that allows you to continue along with curative treatment, or treatment that is designed to slow or stop the progression of your disease. And that's what we all want. Like, we all want to, there's no quality of life without life. So I want my patients to get the best treatment that they can for their illness. But I also think it's equally as important that they do that with, like, the least amount of suffering as possible, feeling as good as possible. So live as long as possible with the highest quality of life. So how can palliative care help fatigue? Well, anybody who needs relief from distressing symptoms like pain or fatigue or stress of a serious illness, that's the space we work in. And so we're really tailored to do well with symptoms like fatigue. The goal is to improve quality of life for the patient and the people that love the patient or care for the patient. And it's appropriate for those with fatigue because we know the statistics. We've clinicians like me doing this for 20 years, we know that at some point in serious illness, the majority of patients experience fatigue. Because the ultimate goal is, giving people the best of what medicine has to offer in terms of cure and disease-targeted treatment, and then putting this extra layer of supportive palliative care on to make sure that they have the best symptom management and quality of life at the same time. Improve survival, improve quality of life, everybody wins. So again, palliative care is provided by a team of people, doctors, nurses, some cases social workers, chaplains, and others. Palliative care teams will be composed of different things in different places, but in general, you're going to have, multiple providers with different levels of expertise that are going to look at things from a full, circular view of your life and try to improve it in any way that it can. And this can be done in the hospital, in a clinic, it can be done at your home. Again, this will vary by geography, but for the most part, it's available in all settings. Best resources that I could recommend for someone who's listening in on this webinar and wants more information, far and away, getpalliativecare.org. It is for patients and for caregivers. There are lists of questions to ask your doctor. Click on buttons for certain illnesses. So if you have a certain diagnosis, you'll be able to find that diagnosis there and what it might mean to you in terms of symptoms and what palliative care can do about it. It's clear, it's comprehensive, it has a definition, it has a self-assessment as to whether or not palliative care is right for you. It gives you information on how to get it. It has a tip sheet on how do you talk to your doctor about it. There's real stories from patients in the podcasts on the website. There's a provider directory, which is searchable. And it's interesting, I was just doing this the other day for an unrelated reason, and I looked in the two places that I've lived most in my life, and the directory's up to date and it's excellent. And the places that I know exist in my hometowns, were there. So this provider directory is super helpful. And then there's a downloadable handout of what you should know about living with a serious illness and what palliative care can do for you. So getpalliativecare.org, by far, just an excellent site for anybody who's living with a serious illness. And whether you're struggling or not, it's just an incredible resource for how to live better with your illness. So in the question part of this, what I'd like to do is just go through the most commonly asked questions, because we address most of the things that are on people's minds from doing these talks over the years. So I'm going to work through some of these and hopefully address the things that are on your mind after listening to this presentation. Who pays for palliative care is a common question. Palliative care is a medical subspecialty, just like other subspecialties, so it's paid for by insurance. When I get a referral, a patient will come to me, and it's just like any other doctor's visit. And even though I work with a team of people, I really just bill under me for my services, and all that other stuff is kind of a bonus in the health insurance world. So palliative care is paid for like any other specialist you might see, and in healthcare. The other thing I get asked is, well, what if my doctor or my nurse practitioner or my PA says I'm not ready? Well, this is where the getpalliativecare.org site is super important, with the tips on how do you talk to your clinicians about palliative care. Because we know in palliative care that the earlier palliative care is involved, the higher quality of life people have. And actually, there's medical evidence that was published in the New England Journal of Medicine that people even live longer on palliative care. So, generally when you bring those talking points to your other clinicians, they become much more receptive to it. And the other thing that I've had people do is, even if you haven't been referred to me, but you found me on the provider directory on getpalliativecare.org, pick up the phone, call, and sometimes I can make a one-to-one phone call with your other clinician to discuss whether it is right for you. And so we're busy, most palliative care docs are busy like all others, but we want to make sure that people are getting the care they need. So we'll take those extra steps, as do most other clinicians as well. The other thing that gets asked a lot is, I don't need another doctor or another clinician or another group of people taking care of me. I just need two that will talk to each other. We live in a very sort of segmented healthcare system where, one of the biggest challenges is who's quarterbacking, who's coordinating my care or communicating all this with all my other doctors or clinicians. And what I would say to that is that's a huge role palliative care plays. Like I say to my patients a lot, palliative care treats pain and symptoms. It coordinates and communicates about your care among all your providers and your family and caregivers. And then we support people psychologically and socially the best we can. And the big part in that middle is this communication and coordination of care, because, making sure that everybody that's involved with your care, if you have cancer, your oncologist, if you have heart problems, your cardiologist, working together with your primary care doctor, your palliative care team, maybe other specialists involved for other things that you have going on, making sure everybody's on the same page makes patients and families feel so much better about the care. It coordinates the care in a way where, one provider is not doing something that's in direct competition or contradiction with something somebody else is doing. And palliative care plays this quarterbacking role really, really well, because we have a team of people that can do it and really look at the whole picture and try to bring that together and summarize it for everybody involved in your care. So those are the three most common questions I get all the time about palliative care. And hopefully today, I've been able to make the compelling argument that you're probably going to experience fatigue. If you're on this webinar, you probably have or are experiencing fatigue, and not to be too down about it, because there's a lot of help for you. Seeking out palliative care would be a first logical step. That team that you get in touch with will, recognize, evaluate, and treat your fatigue like we talked about in this webinar, and get you on the road to feeling better. So with that, I just want to thank you for joining today, and please visit getpalliativecare.org, and I hope to see you soon on another getpalliativecare.org webinar.